Good afternoon, everybody. Thank you for joining us for our first bi-monthly volunteer webinar of 2018. We're very excited that you're able to join us, and we have a lot of great updates from our different departments. And we also have a really wonderful keynote speaker today who is going to be talking about dealing with insurance problems. He deals with them full-time for a living on behalf of Connecticut residents. So he has some great insight to offer us, which will be really helpful. So we have our usual agenda with updates from our main departments. The only change is that I will be, so I just want to make sure everyone can see my screen.
Yes.
Okay, good. So we're going to have just some regular updates from our different staff members. The only one small change is that Cindy Steinberg is testifying up in Massachusetts today, so I'll be giving the federal advocacy update on her behalf. And then, like I said, we'll have our keynote speaker, Demian Fontanella. Just some reminders as we go through the presentation. You can ask questions at any time by typing them into the control panel at the right. We'll have 2 question and answer sessions. One will come at the end of all the department updates, and then one will come after Damian's presentation. If you have to jump off early or you want to share this webinar with anyone, feel free. It should be available online by February 1st. And also, a quick note, on the control panel on the right, you will see a section for handouts. We have about 4 handouts today, so you do need to download those before the presentation ends. If you forget to, just shoot us an email and we'll send them over. And finally, we're going to have a little survey at the end of the webinar, so just make sure to take that before you sign out. It should take like 30 seconds, but it will help us make sure to keep offering webinars that are interesting to you guys. So with that, we're going to just jump into our ambassador update with Lori and Jackie. So Lori and Jackie, I'll turn it over to you guys.
Okay, good afternoon. Emily, can you change the slide, please?
Yep. Can you see it?
Yeah, I need the one before that. Yes, perfect.
Right now.
Okay, as we start the new year, kickoff to Rare Disease Day is approaching right around the corner on February 28th. We invite ambassadors, advocates to host a table or to share your story to raise awareness in your community, which is a great way to get involved. If you're interested in becoming involved in any of the events for Rare Disease Day worldwide, you can visit the link that's listed on the screen. There's many locations, just a few are California, Arizona, Delaware, and there's lots more. In the past years, we've had ambassadors set up a table at the NIH, National Institute of Health, for Rare Disease Day, so we welcome others to join in. Also, no time like the present to get started planning your involvement for our Pain Awareness Month for this year. There's lots of opportunities to get involved, so if you can complete the ambassador activity form, just feel free to get started and we will respond back to you with any questions or concerns. Thank you.
I'm wanting to, I didn't see the January announcement about Michelle Rice. She's being honored for last year's Ambassador of the Year award. If you would like to become an ambassador or an advocate, you don't have to choose between them. They complement each other very nicely. Everybody is raising awareness. It's who you direct it at that helps determine which program you are interested in. So let us know.
Okay, thanks, Jackie and Lori. So that was a quick little ambassador update. We do have a lot of state advocacy updates for you. So Shana is going to give us those. Shana, whenever you're ready.
Yep, sure. So first we'll just dive into the 2018 legislative session in terms of what to expect, some bills we're tracking, and ways that you all can engage. If there's one thing that I've learned about advocacy, it's that this beast is very unpredictable in so many ways. We have seen unfortunate examples of that when we wake up one morning and discover our state reps or senators have introduced what might have been a well-intended bill that regrettably impacts patient populations in a negative way through bills prohibiting, let's say, a certain amount of opioids that can be prescribed, or mandated contracts between patients and physicians, or even eliminating rebate and prescription copays. The list goes on and on. Now, I don't mean to depress any of you, because there are also some examples of how state advocacy has pleasantly surprised the patient population, such as the recent medical cannabis bill in Kentucky, or over in Washington State, where legislators are trying to protect consumers from access charges for prescription meds. So as patient advocates, we need to face the 2018 legislative session knowing that there needs to be some room for fluidity. So we might become initially frustrated with the headlines that we read, or when we read a new proposed bill that doesn't protect those with chronic conditions such as pain. But remember that there's always room for improvement. So what I mean by that is there's always the power of your voice, your story and passion that has the ability to change potentially harmful bills and instead better support your family and neighbors. So what can we expect? Honestly, expect to fight. Expect insurance companies to put an immeasurable amount of resources and dollars towards killing a bill that might force them to make more ethical decisions in the way of treating their beneficiaries. Also expect more limitations to be proposed on specific types of medications like controlled drugs. Now, we're also anticipating 7 states to introduce bills relating to biologics and interchangeability from a biologic to a biosimilar. There's a handful of bills this year will aim to stop negative mid-year formulary changes, also known as non-medical switching or continuity of care. We do belong to state-based coalitions that focus on that issue, as well as step therapy, high out-of-pocket costs for medications, all of which will be taken up again this year in a lot of new states. So we're encouraged to see that medical cannabis, for example, will continue to once again be a hot topic this session, and one that US Pain will be advocating for, as well as reimbursing specialists for expertise in the field of complementary and alternative medicine. Now, we're also hearing some rumblings over on the West Coast that a number of drug transparency bills will be popping up this year, and states across the nation addressing prescription benefit managers. And so all of these topics are just at the tip of the iceberg. So there's so many worthy issues impacting Americans with chronic conditions. And US Pain's advocacy network will keep advocates in those states updated on what's being introduced, why a bill is important to engage in, and ways that you can take action. So here are some ways that you might be able to engage with us this session. You will receive e-alerts from our advocacy network. So make sure that you look at the various ways that you can reach out to target legislators or committee members within those emails. We always provide contact information to reach out to your elected officials, whether via their email or their office phone numbers. And then we provide an email script and or a phone script to make the communications process an easy one. Social media is another great way to become engaged this year. So in certain instances, we'll generate social media kits for you to use. And other times we might just give you a few sample posts within an email alert for you to easily engage with leadership. It takes less than 1 minute to just copy, paste, and share one of these posts. You can also just retweet something that US Pain has, or you can share something through Facebook that we have posted relating to a state advocacy initiative. I also encourage you to visit our advocacy section of our website, because throughout the year we add various components. So for example, position statements, maybe new priority topics, and that's where you'll find our online engagement opportunities. You'll find all of our campaigns there that we've created for you to easily reach out as a constituent to your legislator and to share why you are in support or in opposition of a bill. And with these online campaigns, we usually create pre-written letters or petitions, so that all you have to do as an advocate is enter your zip code, maybe your name or address if you're a first-time user of this program, and then just click your mouse or hit your cell phone button in order to take action. Another way that you can engage is to visit your own state's website, learn about who your state representatives and senators are, click on the calendars, maybe see which committees are holding some upcoming hearings. You can see upcoming committee agendas, and it's a really great way for you to familiarize yourself with how your state presents information to the public and how committees operate. This is important because the more comfortable you are with researching these types of resources, the easier it will be for you to start taking a more leading role in your state as an advocate for this organization. Finally, testifying. We're always looking for advocates to share their voice before committee members on a number of issues. So throughout the year, you'll be getting emails asking who's available to attend an important hearing. And we'll not only provide you with that background info on the bill, but why it's important and ways that you can even help finalize your testimony. We can also schedule a call with you so that way you feel as comfortable as possible leading up to that hearing date. So I know I went through a lot of information in a very small amount of time with that bullet point, but just feel free to send me an email after this webinar if you'd like more details on specific topics that I've mentioned. Also, under the 2018 legislative session, I want to jump down to new position statements. So remember how I said you need to approach this session with flexibility? That's really how we approach not only each session as an organization, but new access issues or patient safety concerns that US Pain believes that it should get behind. So that's why we're working on new statements to make available not only for you as an advocate, but for the public at large. We're tackling various issues that are relevant to the entire population of those living with chronic conditions. So that means we're taking a more concrete stance on issues such as healthcare, prescription transparency, surprise billing, dosage limits for pharmacologic treatments, among other things. So I do encourage you all to visit our advocacy section, maybe sometime, throughout the rest of this week. See the existing statements that we already have up there, because those are great starting points for when you do decide to take action at the state level on the bills that are being introduced this year. And speaking of taking action, we do have a federal bill that we're currently tracking to improve medical research on marijuana, also known as the MEDS Act. So we created an online engagement for you all to partake in, and that focuses on medical research into medical cannabis. The Marijuana Effective Drugs Study Act, which is known as the MEDS Act of 2017, was introduced by U.S. Senator Orrin Hatch out of Utah. And the purpose of this bill is to really encourage scientific research on cannabis as an effective and safe medical treatment. So rather than going through all of the benefits of how this act would have towards Americans with chronic conditions, what we did today is included a handout with this webinar that you all can download and read at your disclosure. So for the sake of time, just read over the bullet points we've provided and then go visit the online campaign to take action. And that handout that we've provided, you'll see at the bottom, has the US Pain Advocacy Network logo on the bottom. So just click on that logo. It'll take you directly to the online engagement. And you can also access the engagement by visiting our website within the advocacy section. And the last thing for today that we have for you in order to take some advocacy action relates to the Americans for Safe Access blueprint called Medical Cannabis as a Tool to Combat Pain and the Opioid Crisis. So Americans for Safe Access came out with this great resource that we've included as a separate handout today. It is lengthy, so make sure you carve out some time to read it over. But some basic takeaways from this report is that it shows us the states where medical cannabis laws might be lacking provisions that could help more patient populations. It also includes some model language for states that don't have medical cannabis laws in place yet, that you might want to take it upon yourself to introduce it to one of your state reps and see if they'll take this up as an issue. And then there's a whole chapter on recommendations from this toolkit. There's also a proclamation I wanted to mention of a state of emergency. And US Pain is going to be looking at the proclamation, see how it can support this model. So what we would like advocates to do is, aside from taking a look at the blueprint, read that proclamation, look it over, and then send us any thoughts or suggestions that you might have, because we may take this up as another advocacy engagement. We do proclamations during September Pain Awareness Month. We do Migraine Awareness Month. So this might be another proclamation that we take up later on this year. Now, just so you're clear, outside of taking a look at this blueprint and maybe coming up with some suggestions for the proclamation, there's no action right now to take on the blueprint other than just reviewing it. So should US Pain or Americans for Safe Access decide to utilize its findings on medical cannabis and the opioid epidemic, you as an advocate will just be more educated on the discoveries found within this toolkit and hopefully ready to mobilize if and when asked. So I know that was a lot, but that's basically what's going on currently with our state advocacy update. As you can see, 2018 is going to be another very busy year, so please feel free to send me an email, shana@uspainfoundation.org, if you have any questions. Thanks, Emily.
Thank you, Shana. That's really wonderful. We have so many different things we're working on. I really appreciate you keeping track of everything for us. And just a reminder again, the handouts are available on your control panel at the bottom. There's a little downward arrow you click, and then you can download the handouts from there. So I'm going to be giving our federal advocacy update on behalf of Cindy Steinberg, our National Director of Advocacy and Policy. As I mentioned at the beginning of the call, she's actually tied up in Massachusetts testifying. So I'm going to just run through her update quickly. If you do have questions, I'll have her email up in a second, so you can contact her directly. So the big news on the federal side of the advocacy table is that the Opioids and Stop Pain Initiative Act was introduced in Congress by Senator Schatz and Representative Welch. And we are very excited about this bill. We support it, and we think that it's going to do some wonderful things for the pain community. So what this bill does is it authorizes $5 billion over 5 years to the National Institutes of Health to intensify and coordinate research on a number of areas related to pain. So that includes the understanding of pain, development of therapies for chronic pain. It also includes development of improved options for medication-assisted treatment and opioid overdose reversal treatments. So that's something we support. It also would help fund components of the federal pain research strategy, which we've been supporting for some time now, which would make a big difference in improving care for pain, and then also the pain therapy screening program. So as you can see, those are a number of things that would be very helpful to all of us as pain patients. We all know we need more treatments. We need more understanding. So this is a big deal for us. So right now, what we're asking people to do is to reach out to your federal senators and representatives and to ask them to co-sponsor this bill. It's very easy to do that on our website. You can look up who your representatives and senators are, and you can just contact them directly. We will be developing an engagement like that, which Shana was talking about, in which we create a form letter for you, and it's as simple as you just signing your name onto the letter, and then we send it along to your rep. So that will be coming probably in the next week or so. But in the meantime, we wanted to share a fellow organization's social media toolkit. This comes from the Alliance for Headache Disorders Advocacy, another organization that supports the bill. So that's going to be, again, in your handouts. It's labeled the Opioids and Stop Pain Act Toolkit, and it's essentially just a few different tweets and Facebook posts that you can copy and paste and share and help spread the word and get some attention to this bill, because like I said, we are very strongly supporting it and hoping it will move forward, because it's very necessary, as we all know too well. So that's the federal advocacy update. So now I'm going to turn it over to Casey Cashman, Director of Fundraising, to give our fundraising update. Casey, whenever you're ready.
Hello, everyone. So we have some pretty exciting news. That picture right there is my son, Tyler, and we just hosted the 3rd annual Points for Pain game last week on January 11th. So far, we have a little over $3,000 raised with a couple companies who are now going to be making some donations. So his goal was about $20,000, and all of that will go towards children living with chronic pain. Anybody who wants to get involved in a Points for Pain game or host one at their school or somewhere in their community, please reach out to us. It is very simple and easy to do. Tyler and I have put everything together for you guys, and would be there to help support you. A fundraiser that we have coming up, one of them is Crazy Sock Day. Is not the fundraiser, but it's actually a day where it kind of takes over social media, and we just ask people to put on fun, crazy socks, take pictures of them, and hashtag Crazy Sock Day 18 and hashtag US Pain. A girl by the name of Melanie Dickens started this, and then they actually have a Crazy Sock Walk, which is then the following Saturday. the 27th is a fundraiser down in Florida. So around the world, you know, it's pretty easy. Everyone can just put on some crazy fun socks, take pictures of them and put them on social media. And that way we're showing support, we're uniting one another. Different schools have gotten involved and, you know, taken big group photos and things. So it's actually a lot of fun to, I'm not really a foot person, but to see all these socks is kind of funny. Pennies for Pain is another fundraiser that is actually coming up. We have another young lady who's in high school who is I've been working with, and she actually came up with Pennies for Pain, and it's just like a penny war that everybody else is thinking of, done at schools. So if anybody is looking to do that type of a fundraiser as well, we have that. US Pain is, you know, as you know, we don't charge for any of our programs or services, and so we're always looking for fun and creative ways for fundraisers to take place. And there's really a fundraiser in no matter where you live, there's some type of fundraiser you can do. We've had a lot of people who have done for their birthdays the fundraiser on Facebook where you can donate to a local charity or charity of your choice. And a lot of people have selected US Pain Foundation. We also have Amazon Smile, which doesn't cost you any more than buying the product initially, but then we get a percentage of that directly to US Pain Foundation. So even if you can't participate in these events and you can't donate to them, that's perfectly fine. We don't expect everybody to donate to these, but if you can help share to raise awareness through our social media accounts and so on and so forth, that's a huge part of this as well. And again, if anybody has any questions or concerns, or you have any great ideas, I mean, all three of those events all started from 3 kids who said this was what they wanted to do. And all 3 of them, well, 2 of them will be a huge success. And I can only imagine that Pennies for Pain will be as well. And we're here to help you, walk you through it, any type of fundraiser that you guys can think of or that we've already got created for you. So thank you.
Thank you, Casey. It's really exciting to have so many events this month going on. So we have just a couple quick general updates, and then we'll be getting to our keynote presentation. So Gwen, I don't know if you're still with us, but if you wanted to just let us know about these trainings coming up.
Yes, can you hear me?
Yeah, we can, thanks.
Great, okay. So we're going to be having 3 trainings for people that want to become chronic pain support group leaders. Last year we had 2 trainings, one in Tucson, Arizona, and one in Connecticut, and the result has been 8 new groups. And excuse me. So this year the 3 trainings are going to be in March in Phoenix, and we're just working on the hotel arrangements. So it'll either be the weekend of the 2nd to the 4th or the 16th to the 18th. Then in June, there'll be a training in Chicago that will be either the 1st to the 3rd or the 15th to the 17th. And then October in New York, which would be October 19th to the 21st. It's a 2-day training. I and Cindy Steinberg run the training, and we give you a total experience of how to run a support group. We teach you different techniques to use in the group. We provide you with a lot of information, CDs, a book, Making the Invisible Visible, and a lot of handouts, so you're not there alone. And then once you finish with the training, then we have a 1-month, each month we have supervision, and all the support group leaders call up and everybody gets an update of what's going on. And we, help each other, deal on certain different issues about, how to handle people in the group, or if certain questions come up, how do you reply? So you're never alone. You have supervision all the way through, and it's a wonderful experience, not only for the group leader, but also for all the people that are attending. And we want to have as many support groups, across the country as possible. And along with that, we have 2 calls called Pain Connection Live conference calls twice a month. And we're working on starting a 3rd one that will probably be on the weekends. So we'll have more information about that. Thank you.
Great, thank you, Gwen. So I'm just going to give a couple updates on behalf of Paul, our president and founder. The first one is very exciting, and that's that US Pain is now the owner of Pain Pathways magazine. You may have seen this magazine in your pain clinic or a hospital, but basically it covers everything about chronic pain. Our ownership won't really change much about the magazine. You will see, as always, a little section from US Pain in each issue talking about the things that we're working on. But we're very excited about that. And one other thing that's really fun is that there's going to be a short promotional film coming out that highlights some of our US pain advocates and ambassadors. And it's from the maker of a film called Becoming Incurable. I don't know if anyone's heard of this already, but it's a feature film about chronic illness that's going to air in April. And we are very pleased to be able to sponsor this film. We believe it's really important to bring awareness to chronic illness and invisible pain and incurable diseases. But as part of that launch, we'll be having this little promotional video available, and we'll be sharing that on Facebook. So keep an eye out for that. Maybe you'll see some of your US Pain family featured. So yeah, so those are all of our staff and department updates. So we'll have a few minutes for questions. If anyone has them, you can type them into the questions bar on the right. And if you can't think of anything now and you think of something after the fact, you can always email all of us. These are all of our different emails. And finally, this call is open to people who are volunteers and also those who are interested in volunteering. So if you're someone who hasn't signed up as a volunteer yet, we encourage you to do so. The address is uspainfoundation.org/get-involved. And that's where you can fill in your information, and we'll send you updates about all of our latest news and happenings and ways that you can get involved and take action. So I see one question, which is for Gwen, and it's, how can we find out about the dates for the support group trainings once they're available?
Yeah, I mean, if you want to send me email, just send me email, Gwen, GWENN, @uspainfoundation.org. And we'll also send out a release as soon as we find out the dates, because, we want people to apply. There's an application. And I just do a phone interview just to, talk with everybody to see their experience and see if they're a good fit, for our programs. So it's Gwen at uspainfoundation.org.
Great, thank you. And one other question is for Shayna, if you're still there, Shayna. Someone was asking about whether or not they need to be an advocate in order to partake in the campaigns, or if they can just participate some other way.
Sure. Yeah, no, so all of our campaigns are intended for the public at large. We always, of course, encourage people with chronic conditions to consider signing up as an advocate. But we do make all of our campaigns public, just so that way, if caregivers, for example, wanted to participate, or physicians wanted to join in, then they could do that as well. What we try to do is to highlight all of our online engagements beforehand to our advocates. There might be times when we have online opportunities or e-alerts going out just to advocates, and we don't publicly make it, available, or, it's online somewhere, but we might not be marketing it as heavily as some others. So it's definitely a good idea to sign up as an advocate, because then you won't miss any of the monthly updates that we are sending out, or timely advocacy engagements that might relate to your specific state. But in terms of the online engagement, anyone can access those.
Great, thank you so much, Shayna. And one final question before we get to our keynote presentation was how to find prior webinars in this series. And to do that, we record all of our webinars and then post them online. So the address for those is www.uspainfoundation.org/get-involved. So that link down there, but one more backslash and just webinars. And I believe I'll have that link at the end of the slideshow as well, so you can make sure to look for previous topics and those keynote presentations. All right, so with that, we're going to move along to our keynote presentation. I'm just going to briefly introduce Demian. He is the general counsel for the Connecticut office of the Healthcare Advocate. So Demian is a lawyer by training and a former Air Force medic. He has worked at OHA, so the Office of the Healthcare Advocate, also known as OHA, helping Connecticut residents deal with healthcare insurance issues since 2011. So this is really his day-to-day job, is fighting with insurance companies on behalf of, just the average person in Connecticut. And in 2016, the Office of the Healthcare Advocate saved state residents more than $11 million in healthcare costs. So this isn't just what Demian and his office do every day, it's also something that they excel at. So he's going to have a lot of great information and insight for us to kind of learn how to navigate insurance issues and hopefully avoid them in the first place. So Demian, if you're there, let us know.
I'm here.
Great. All right. Thank you. Let's get started.
Okay, so first, thanks for inviting me to participate in this. This is a huge part of what we do as an agency. Emily and I have been chatting, and I got a little ambitious with the slides, so I'm going to move fairly quickly through my slide deck, hoping to touch on some things of interest to those that are on the webinar and leave some time for questions. But I'm always available after this is all said and done via email or phone as well. So without further ado, let's start moving ahead. So OHA, next slide, as Emily said, is we are a state agency. We're kind of unique in the nation. Not really many organizations exactly like us. Next slide. Our primary mission is threefold. First, education. I'm sure most of you on this phone call, myself included, have had challenges dealing with and understanding just exactly how to use their insurance, how to navigate the healthcare system, and to maximize the resources that are available to them, especially if you have maybe a not very well understood or not well researched condition or treatment recommendation. So getting out and helping people understand their rights, their obligations, and where there is help available is one of the three key prongs that we pursue. The next one, next slide, is direct advocacy, and this is where this is the bread and butter. People come to us, they have questions. Could be a simple question as to, I got a bill for $300 from my doctor. I thought it was covered. Why did I get this bill? And helping them understand if their plan processed it properly, and if so, why. But if not, then going after the insurer to make sure that the claim was processed the way it should have been, ironing out any wrinkles. Most often, and we'll talk about this in more detail in a minute, people come to us because they've been denied care. Maybe they've been denied access to a particular provider or a particular type of provider or a service or treatment. Could be a medication, could be a particular therapeutic intervention, surgery. And if the insurance company says, that's great, but we don't think that you need it, most of us can't afford to pay for it out of pocket. So people come to us and we actually do the research and draft the appeals on their behalf. And then the third piece is systemic advocacy, the policy work. And this is where we take all the experiences that we get from doing outreach, speaking with folks engaged in the community like yourselves, and our individual client cases through a fairly robust data tracking system to understand the trends that we're seeing, to understand some of the policy challenges where the law could be improved. And through capturing and synthesizing this data and working with our partners, both within state and outside of government, we can help to craft meaningful policy recommendations that we then pass on to our legislators, both state and federal. So that kind of sums up what we do very briefly. Claims management and appeals. This is really the bread and butter of the average consumer, the average person who is trying to engage in the healthcare system. Most of us don't go see the doctor just because we want to. We go because we need to or we have to. And understanding your rights, understanding how the system actually works, and understanding the differences between the systems that you may have to participate in. And by that, I mean you as a patient have one set of expectations and needs. The provider, your doctor, and their team has an entirely different set of expectations and policies and processes that they follow, all focused on you and optimizing your outcome, hopefully. But oftentimes somewhat a little bit different. But then the insurer, the payer, and for most of us who have commercial insurance or even some sort of a public plan or a combination of the two, their approach towards determining what should be covered and what shouldn't be isn't always well aligned with what the doctors or the clinical providers say. So understanding the kind of the tensions between all these different players is very helpful in navigating the system and minimizing the barriers. And that's what I'm going to touch on a little bit today. Okay, next slide. So as I kind of said, it's really helpful to understand the landscape within which we are operating. And one thing that we're talking about, at least with the commercial insurance, so if you have insurance for your employer and you've gone out and bought it through either one of your state exchanges or on your own directly from an insurance company, you still need to understand what kind of insurance plan you have, whether it's self or fully insured. And I'll talk about that in a little bit. But it is a very important distinction because certain laws apply to one type of plan that may not apply to another type. And that's something that very few people understand, including your doctors. Next slide. So a self-funded, self-insured plan is one where, short version, I've never seen one that is not employer-based. I don't think an individual could participate in a self-funded plan on their own. So these are plans where the employer, at the end of the day, pays all the medical bills. These are usually large organizations, large businesses, corporations. And they can afford to absorb the risk of some of their employees getting very sick over the course of the year and having a lot of costs. The benefit of being self-funded is it usually saves up to 10%, sometimes even more, in the overall healthcare costs of the plan because the insurance company with who they contract with doesn't assume the risk of some of those employees becoming sick. All the insurance company does is administer the plan. They come up with the network, they negotiate the contracts, they give out the cards, and they do all the claims management and processing. But at the end of the day, the employer pays the bills. Now, this is important because these are what considered ERISA plans, and they are subject only to federal law. Now, we live in Connecticut, or I live in Connecticut, and we have very generous benefits here. We have a second or third most state mandates for health insurance coverage, which does add to the cost of the plans here in the state, but it helps those people that benefit from the mandates. However, for those people in our state which have self-insured plans, which is approaching 60% now, they don't benefit from those mandates at all because self-insured plans aren't subject to state law. So the first thing you need to do is if you're looking at your insurance and trying to decide whether something should or should not be covered, you need to understand which law even applies. And this is one of the first questions. Is it self-insured or, next slide, fully insured? Fully insured is the typical plan that most of us have. If you go to Anthem or United or Aetna or whatever plans you have in your area and buy a plan yourself, or if you go through your state exchange to buy a plan, those are going to be fully insured plans. Most smaller or mid-sized employers also offer fully insured plans. And that's kind of like the car insurance where you pay your premium, the insurer absorbs all the risk and pays all the bills at the end of the day. But there's more risk, so they tend to charge a little bit more. But the perk here is that those types of plans are subject to state law. So any laws that our state passes to protect the residents of their state do apply to those plans. So for a Connecticut resident, knowing specifically what type of law applies and what kind of a plan they have is the place they have to begin the discussion about whether a service needs to be covered or not. Okay, next slide. Now, some basic things about claim management. You've received a service, and a lot of this is done by your doctor. If you go to an in-network provider, almost all of this has to be done under contract between the provider's office and the insurance company. You shouldn't really have anything to do with any of these. And that's something really important to remember. Your insurance plan is a contract. you're paying some amount of money a month, or someone is if you have a subsidy through the Affordable Care Act, to an insurance company to provide a service. That service is giving you access and paying for medical services that are covered under the plan. So I mean, there is a legal obligation that they engage in certain conduct, this being the most minimal requirement that they have. They have to submit the claim in a timely manner and in a complete manner. And I kind of emphasize this because it's not at all uncommon for a consumer to come to us with concerns about a service that they need, or where the provider, however well intentioned, did not give the insurance company much information at all, despite maybe a follow-up request from the insurer saying, we can't approve this claim right now because we don't have enough information. Well, doctors will sometimes, however well intentioned, write a letter saying, well, this should be covered because this patient's been treated by me for X number of years and this is what they need. That doesn't do any good. So once the claim has been submitted according to the insurance company's processes, then it can be reviewed for whether it's going to be covered or not. Okay, so next slide. This applies to pretty much everything in life these days, unfortunately, but every time you talk to anybody about any kind of a service, you need to write down who it was, when it was, and what they said. This, even if you're calling your doctor's office to schedule an appointment or to confirm that they checked with your insurance, make sure you know who said what and when, because it's not at all uncommon for there to be misunderstandings or miscommunication about how a plan is applied or what the terms of the particular plan may be. Pre-authorization versus pre-certification, medical necessity versus an experimental investigational denial. Whether a denial is because the insurance company has determined that this requested service doesn't meet their definition of medical necessity, or they just, as I said a minute ago, didn't have enough information to make a determination. So getting all the information and tracking all of these conversations while you try to do it, sometimes it will come down to that. I've had cases where we've had clients where we had good evidence, but the clinical evidence was kind of on the fence, but we could point to procedural abnormalities where the consumer did what they did everything that they were obligated to do under their plan, and someone else dropped the ball. If we can prove that, then they can be held harmless from any liability. Next slide. So an adverse determination, that's the statutory, the technical term for a denial. And one of the first things you have to do when you get a denial might seem kind of common sense, but read the letter. First, you're supposed to get a letter under law. You have to get notice if you've been denied something. And it's supposed to state exactly what it is and why. Now, that will vary greatly, and a lot of times you'll need additional information to clarify that. But these four main points are things that you should have included in the letter denying a service. And if it's not, you have a right to call the insurance company and ask them for these pieces of information, if they're applicable. Specifically, the first two. Self versus fully insured, you should certainly know, because as I mentioned, knowing which law applies is important to understanding whether you have a legal remedy or not. And screening versus diagnostic goes towards preventive services, which we'll not really touch on here. So next slide. Proving medical necessity is, as I mentioned a few minutes ago, based on an assessment of the clinical merits. And this is something that looks to the scholarly, peer-reviewed clinical base of support for any given treatment. The federal advocacy update, I was excited to see that the proposed legislation to boost NIH funding to promote research, that's huge, because right now, in this area, there is not a lot of really good, robust data or clinical peer-reviewed articles or large studies showing and supporting the efficacy of certain interventions. That is the kind of evidence that we need to be able to bring to bear again with the insurers to make the case that they should overturn a denial. Sometimes update their clinical policies. And that's what the utilization review process and the last bullet here is referring to. It's utilization review process is when an insurer gets a request for coverage, they'll review to make sure it meets the standards and satisfies all the other internal processes. So next slide. An expedited appeal is one option some people have. I only mention this is because in some cases, if you're out of medication or you need to have some sort of a treatment emergently, you can request an urgent expedited appeal from your insurer. The standard for that is that if delaying the service or treatment would seriously jeopardize the life or health or your ability to achieve maximum outcome, achieve your prognosis, you could consider filing an expedited appeal. Usually you do that very quickly. You get a turnaround within 3 days. The challenge here is getting enough information to the insurance company within the short time frame so they can make a decision with all the information they need to have. But these have worked out very well for some people in tight spaces. Next slide, please. This is a federal reg I've cited, which hardly anyone knows about, but this is important if you're actively in treatment, and typically it's in an inpatient type of a setting or a residential setting, or in an ongoing course of treatment, and it's been denied. So say you're receiving some sort of a pain management therapy, and it's been working, and suddenly it's denied. Well, you can appeal that because it's been ongoing. And so concurrent means a change of a determination mid-treatment. Under federal law, if someone is in concurrent treatment, the insurance company has to continue to pay for that service until you have had a chance to appeal that. There's a lot of ambiguity about the timing here, but the federal law that's what it says. It's pretty straightforward. I think it's fairly unambiguous. I argue the timing is whatever the timing is. We have timelines in statute as well. But that is something to help remember if you need coverage. And then these are the basic timelines that we have. For urgent care, like I said, you get a decision within 3 days. Not urgent care, you get it if you haven't received the service within a month, if it's a retroactive denial. So you already got the service, you got the medication, whatever it was, and then you got something saying, well, we're not going to cover it. They have 60 days to make a determination. And then if we end up going to an external appeal, which is where a neutral third party reviews the claim, you have 120 days to do that from the last internal appeal. All right, next slide. All right, so how do you get through this process? Next slide. And next slide. This kind of repeats a lot of the same stuff we talked about already. This looks like a duplicated slide, so we're going to skip this one. All right. As I said, I had a lot of slides in there, and Emily cleaned me up. So these are the 4 main reasons we get denials. Insurer says either it's not medically necessary, what you've asked for is experimental, which means it really doesn't have the clinical support. We don't know if there's a good cost benefit to us paying for this. It's either not a covered benefit, it's just not listed under your plan, or what you've received is from an out-of-network provider. All right, so next slide. Medical necessity is the most common type of a denial that we'll get. And as I've mentioned earlier, medical necessity is essentially based upon clinical policies that the insurance companies, public or private, Medicare, Medicaid, and all commercial payers have clinical policies which set forth essentially checklists for what services should be covered for which conditions and what evidence they need to support that. Okay, next slide. And I kind of just said what this is. All right, so next slide. So this is a sample of a denial letter. And this is actually a pretty good one because if you'll see, it shows that they've identified the member, identified what they're looking for, and from who, and then why they denied it. That's huge. I mean, a lot of times we'll get a letter saying you've requested a service from Dr. Smith and you don't think your plan covers it, and that's it. That's useless. This gives us the information we need to go on, to start with at least. The next slide shows the next page of this. And it goes on to even point out that they had an independent clinical peer review the request and make a decision as to whether they agreed with the denial, and in this case the reviewer did. But it gives all the information that we need. It actually summarizes the member's medical history relevant to the request. And the next slide. Next slide, please. On the next slide, the last page of the letter does show that it lists the specific clinical policy that they used, which is important. Okay, so next slide, or you can skip 2 slides, Emily. Can you still hear me? Okay, so I'm going to just keep talking in the interest of time. I know we're running up on 2 o'clock here. So when you get a clinical policy, and we'll get to those slides shortly, that is the checklist that you need to go to. So if you've had a denial based on medical necessity, as I said, which is going to be one of the more common reasons that a service will be denied, the first thing you need to get is the denial letter showing you specifically what did they deny and why did they deny it. When you know that, and you know that they're actually considered the right thing. I've actually had denial letters that denied a service that the member hadn't even requested. Once you know that you've got the reason for the denial, for the correct service, and the clinical policy that they used, you take that clinical policy and you put it into an appeal letter. So if anyone's driving the slides, we can move forward some slides here. But
sorry about that, Demian. I think that this is Shana speaking. I believe that Emily's power just went out, so she's just trying to get it back on so she can advance the slides, and we're going to see if I can maybe log on and take control.
I can ramble away anyways. I do that very often, constantly. So,
actually,
I don't.
Yeah. Okay. Go ahead.
So when you get this clinical policy, and typically I can go on and Google it. When we get to the next slide, you'll see that it actually shows the name of the policy that they used. You may have to ask for that, but once you have the policy, you can request it from them. They have to, by law, send it to you, but it's easier just to Google it. You get the entire policy, you figure out where in the policy your specific diagnosis is discussed, and look at the criteria that they list. There's usually a few points that the insurance company will say, okay, for this particular condition, you need to satisfy X, Y, and Z before we will consider it to be medically necessary and approve coverage. Now, those are based on those scholarly peer-reviewed articles and clinical studies that we talked about a few minutes ago. They may not always reflect the most current state and understanding of medicine, which is where partnering with your provider is very important, because that can really help. Your provider can really help get the additional evidence that we may not know. I don't personally subscribe to professional academic magazines, so I don't really, read the New England Journal of Medicine and see what the latest studies are. I could, I just don't. I would assume if your provider is recommending a particular course of treatment, they understand that this is the newest and most effective innovation, but it has to have good support behind it. All right, so here you'll see at the top of this, it says CG Drug 09. That's the policy that we would want to look up. Next slide. All right, so when you're drafting an appeal, you've been denied for medical necessity or really anything else. All right, so here's the policy, and you'll see on this page, it identifies the various diagnoses that someone might use IVIG therapy for, and then what the criteria are. So for the first one, for example, if you have antenatal alloimmune thrombocytopenia, you have to have antibodies to the paternal platelet antigen in the maternal serum and one of those things. If you can satisfy those with a specific reference to your medical records, labs, x-rays, progress notes, whatever you have, that will satisfy it. The insurance companies, by and large, or at least the people doing these reviews, are not looking to deny. What they're looking for is to be able to prove to their bosses that when they approved coverage, they satisfied these internal policies. So when I do a denial letter, an appeal, I include their own internal policies against them. All right, so next slide. And next slide. And one more. So this is kind of the template. Want to identify who it is, their ID number, what you're looking for. If there's like a specific location, you could also put that on there. But it's just like college writing. Introduction. Tell them what you're going to tell them. The body, number 2. Tell them and give them the support and the evidence. And then number 3, the conclusion. Tell them what you told them and why. The clinical policy goes into number 2, as I said. So next slide kind of gives a sample. So here I introduced the issue for this young man, and it was actually for a lumbar spinal fusion. Explained, yep, we understand why you denied it. We think you're wrong. Here is your actual clinical policy. And so for all the various criteria that they required, I provided evidence to this individual's medical record to prove that. I want to make it as easy as possible for the reviewers to look and say, yep, okay, that's our policy. Evidence supports it. This case, it was overturned, and this gentleman was able to get this surgery covered. Next slide. And next slide. No, that's it for that one. So an experimental investigational denial is pretty similar to a medical necessity denial, except it's a slightly higher bar. What the insurance is saying with an experimental investigational, I have seen this not infrequently with pain management clients as well, is that they're not necessarily disputing that there's potential benefit to that intervention for that member, but that there isn't enough clinical evidence to support that. And that's where a lot of these new innovative approaches may be denied, even if there is going to be some benefit to them. In order to do that, you want to go back. You want to get the clinical policy, because there will still be a clinical policy. You want to make sure that it has the most current clinical evidence. I've had clinical policies that actually cited evidence as a basis for not covering it, which were outdated. And when I was able to go back and show them, look, you used this study from 2008, but there was another one in 2012, which actually supported the use of this intervention and has all sorts of good data behind it. They agreed, they updated their policy, and they ultimately covered it. This is where partnering with your provider, especially if it's a really new, really novel, innovative new approach, partnering with your provider is going to be helpful. But it's the same calculation. What standards are they applying, and do those standards satisfy the standard of care that the provider world has to operate under? One, I think, very important distinction to make here is your doctors, as I mentioned a while ago, don't necessarily draw the line when they're considering what the best treatment option is for you, and this is a good thing. They don't just draw the line at what they can find really, really robust support for. Hopefully your provider is going to be able to think outside the box, consider some new innovative approaches that may not really have been used very widely, but could be more appropriate for you. And if there is no other standard intervention that will give you the outcome that you need, and an experimental intervention is the only legitimate, reasonable approach, and it does have some clinical support behind it, that in and of itself is a good argument to make, that this intervention, however experimental, is the best option for this particular individual patient based on these reasons. I've made arguments similar to that for, actually it was another lumbar fusion for a very young man whose requested intervention actually hadn't even had FDA approval yet, but because of his history and his age and the prognosis long term, it was covered. So these are slightly harder to overcome, but they are not insurmountable. They just take more work. All right, next slide. Yeah, I actually just talked about all that. So that's where you just look at the policy, make sure it's got all the evidence that you need. And as I mentioned, second bullet, the only treatment that will work for you. And that's where you do need your medical record. Doctor can't just say this is the only thing that's going to work. You have to go in. Your doctor either, or if your doctor won't do it, you or an advocate working with you, summarize the history, summarize how you've tried all the standard conventional therapies and they haven't worked, and why only this experimental approach will be beneficial for you. Next slide. Not a covered benefit. Yeah, this is a weird slide. I don't know why it's got the auto advance in there. But if something is denied as not being a covered benefit, that's a bit tougher to overcome. Those are typically correct. And really all that means is that you've requested a service that is just not covered under your plan. So absent something showing that that particular requested service, whether it's a medication or a particular type of therapy, actually violates the law by not being covered, unless you can prove that, the plan is permitted to limit coverage for certain things. We have a very weird exclusion in our state for speech therapy. It's limited to a very, very narrow range of applications when it could be applied far more broadly. But under the plan that I've seen this issue in, it's just excluded. And while it's medically indicated for the reasons that people have sought coverage, it's just not covered. So sometimes you just run into a wall and there's not much you can do there. And then the last thing is out of network. And this comes up a lot. And we've seen this time and time again here with people in Connecticut looking for a good pain management provider. We had a couple of large closures in our state, which left a lot of pain patients struggling with chronic pain and not really being able to find a provider to manage their pain moving forward. So if you actually need to go out of network for surgery, for a regular, ongoing care, therapy, something like that, does that mean your insurance company has to cover them? Next slide. Maybe. Next slide. What you have to do, your insurer, so once again, remember this is a contract. Your insurer is taking the premium dollars in return for providing access to appropriate medical providers to deliver the services that you have covered under your plan. So if the service that you're trying to receive is covered under the plan, so it is a covered benefit, and you can't find a doctor, either one that is appropriate for what you need or that can see you within a reasonable amount of time and within a reasonable distance from your home, then you have the right to request that you see an out-of-network doctor as if they were in network. So the insurance company under federal and state law is required to make sure that they have adequate networks of providers. And what that means is they have doctors that can provide all the services that they cover within reasonable distance, reasonable time to your home. Now, those terms right there are a little bit amorphous. There aren't any, sorry about that. There aren't any really clearly defined non-proprietary standards, but typically it's 30 minutes, 30 miles, or 30 days to get in. Next slide, please. If you do need to go out of network, the first thing you have to do is work with your insurer, whether it's public or otherwise. Give them an opportunity to find you an in-network provider. That's usually going to be futile, very annoying. What you will end up doing is getting a list, usually something that they went to their provider directory, printed up the first 200 providers that they got in return to a search, and they will send it to you, either email or mail. However, if you don't do that, and then you go to an out-of-network provider, they can justifiably deny covering you, stating that, well, there were in-network providers available. It's up to you, the member, to prove that none of the providers they say were available actually were. Once you've done that, once you've received the list and you've made the phone calls and all the doctors that they said were in-network either weren't or they couldn't see you, either not taking new patients or their next appointment's 3 months out, then you go back to them, excuse me, and tell them, well, I can't see them, so I need to go see another doctor. I want to see this one. It's up to them to figure out how to get an out-of-network provider to see you at whatever negotiation they come up with. But you cannot be held responsible for anything beyond what your normal co-pay or co-insurance would have been if they were actually in network. All right, next slide. I just left those in there because a lot of folks that I've worked with that have chronic conditions, including chronic pain, or often chronic pain and chronic conditions, ask me this question. The Social Security disability process is very, very similar to the medical necessity or experimental investigational denial process. If you're, hopefully you don't need to do this, but if you ever do need to seek out Social Security disability and you need to apply for it, the first thing you need to do is go to the Blue Book. And that's another thing you can Google. That is an online list of all the conditions that they consider disabilities or could be considered for disabilities and how they measure that. That's the first step. Go there, just like the clinical policies for the insurers, find your condition and see what particular standards that they will use to measure whether you actually have a disability under their policy or not. That's helpful because the majority of initial applications are denied. Even if you do hire somebody at probably fairly high cost to do it for you, there's still a lot of initial denials. This helps to reduce that significantly. If you know what they're looking for and you can give them the evidence that they need specific to that, it lowers the burden of those doing these reviews. That's the process. Understanding the system that you have to work within, figuring out the rules of that system, and then providing the information to satisfy those rules is the most effective way of ensuring that your insurance coverage, once again, public or private, gives you the best benefit with the least amount of challenges and headaches, because seeking medical care is challenging enough in itself, especially if you have a significant problem. The last thing we need to do is have to worry about insurance problems as well. So understanding how the different parties operate, that your doctor, just because they say this, I read an article, this is a great new intervention, doesn't necessarily mean the insurer even should have to cover it. There's different rules, but at the end of the day, they're all focused on you, the patient. So these were some very, very, very quick insights into how to understand the landscape, how to understand what your rights are and your obligations, and where the resources may be available to help you navigate it. So with that, I will stop. I don't know if there's time for any more questions, but I am more than happy either now or afterwards to answer anything.
Demian, this is Shana. I think we're just waiting for Emily to comb through any of the questions that might have come through. Okay. Are there any specific, while we wait, are there any specific websites that you think our advocates today should be joining who aren't from Connecticut?
Specific to insurance coverage?
Yes, I mean, is there some sort of a foundation that the Connecticut office kind of used as its basis or blueprint for creating its online website? Or should we just look at the...
Yeah, we were actually kind of the first in the nation with this model, and while there are a lot of other advocacy organizations around the country, including government-based, there's not really any like us. One of the unique things about our agency is that we are an independent watchdog. So we are not housed within an insurance department, which honestly most of the consumer advocacy units around the country that I've been able to find are. Most of them are in either that state's insurance department or in that state's attorney general's office, which brings with it policy limitations, concerns about political impact of zealous advocacy potentially, maybe even a conflict of mission. You know, the insurance departments tend to be the regulator of the insurance industry and have to try to remain somewhat neutral. But as a patient advocate, we see a lot of things that the industry does, which we really don't want to and shouldn't stay neutral about. So being able to be independent and have funding that is separate and distinct from any of those other entities really allows us to stand up and speak out on behalf of consumers within our state. There are a few nonprofits across the country that do engage in some limited advocacy, but once again, most of the non-government entity advocates that I found that do the kind of work that we do, like on an individual basis, helping people evaluate their denials and draft appeals on their behalf, tend to be fee-based. And to be completely frank, some of those that I've seen are pretty horrible. I had one client got paid $1,000 for a letter that was clearly a boilerplate template that had maybe one paragraph out of 7 pages that was specific to the member. And it was it failed. I mean, there's nothing that they could do about it. So I guess no. I mean, you can certainly come to our website. I'm hoping to get it updated and have a lot more user-friendly information, including a step-by-step. This is how you do an appeal with examples and templates, just like I had in the slideshow.
Okay, another question that came in is, has the OHA advised the CGA regarding the self-insured loophole that allows plans to avoid Connecticut law health mandates?
Oh, they're very aware of that. Yeah,
okay.
we engage with the General Assembly very frequently, and the question of self-insured versus fully insured always comes up. But the legislators are very aware, and there's nothing that we can do under state law because that body of plans is carved out under the Supremacy Clause as being exempt from state oversight and regulation.
And is there any legislation that's being proposed right now to address that specific issue?
No. And I can't imagine any. I mean, that would be a fundamental change to the legal framework of our nation and would challenge federalism at its roots.
So then there wouldn't be any legislation, if legislation were to be proposed, let's say this session or next session in Connecticut relating to that mandate, would your office support or be able to support something like that?
Support making self-insured plans subject to our law?
Regarding the self-insured loophole?
We probably wouldn't support it. I don't know if we would actively oppose it, but the only reason that we probably wouldn't weigh in very much and why I don't think we would ever see it is because even if we passed it, it would have no effect. Our law cannot overrule federal law. So we could pass a law tomorrow saying every insurance plan, whether fully or self-insured in the state of Connecticut, must incorporate all of our mandates and be compliant with all of our other laws. And the first insurance company that had a self-insured market of business would just sue in federal court saying, no, you can't do that. Federal law supersedes this under ERISA. So
okay.
It would require a change at the federal level.
Gotcha. Okay. Fair enough.
Not really,
hi guys.
but
no, I know. Fair, not fair.
Can you hear me? This
yes,
is Emily.
Yes.
Okay. We're having some technical difficulties over here at Constitution Plaza in Hartford. Our power keeps going out. So I just wanted to apologize about that. Sorry for the lag in slides and in audio on my end. But thank you so much, Demian, for that really awesome presentation. I feel like I learned a lot and I thought that I knew a lot, so that was great. And we've gotten some other comments from people saying that they also learned a great deal. And one quick thing I wanted to point out, so Damian's office can only work with Connecticut residents. I know we have a couple Connecticut people on here, but a lot of people are from other states. Fortunately, he put together a list of similar offices across the country by state. and that's going to be in your handout section of the control panel. On the right, it's called U.S. Health Advocates 2017. So if you do have a health insurance issue, you can try reaching out to these various offices. They're all very different, and some have different services. Connecticut's very lucky to have a very robust office of the healthcare advocate, but it's always you can always check and always try and see if they can help you with problems that you might run into. So thank you everyone for participating and sticking with us through our technical difficulties. We appreciate it a lot. Our next call will be March 20th at 1 p.m. and we'll be announcing the speaker shortly. And again, thanks to Demian. We really appreciate it.
Thanks for having me. And if anyone has any questions you just have for me, regardless where you live, just feel free to shoot me an email. I'm more than happy to have a chat with you.
Okay. And what's your email address, Demian?
It's Damian.Fontanella@ct.gov.
Okay. Excellent. We can send that out to everybody just to make sure you have it. All right. Thanks, everyone. Enjoy the rest of your afternoon.
Take care.